Senior Academic Half Day, Malignant Haematology. Beth Harrison. Department of Haematology. University Hospitals Coventry and Warwickshire NHS Trust. Normal hematopoiesis. Investigations in malignant haematology. Approach to a patient with pancytopenia. Diagnosis and management. Case 1 HB 8.6 WCC 1.2 platelets 12 35-year-old male. 6 weeks recurrent throat infections. 2 weeks easy bruising. HB 8.6. WCC 1.2. Platelets 12. Pancytopenia, he will need a bone marrow examination. Bone marrow examination. Normal bone marrow aspirate. Normal bone marrow trophine. Case 1 HB 8.6 WCC 1.2 platelets 12 35-year-old male. 6 weeks recurrent throat infections. 2 weeks easy bruising. HB 8.6. WCC 1.2. Platelets 12. HB 8.6. WCC 1.2 plus. Platelets 12. Equals. Acute leukemia. What is acute leukemia? What is a blast? What is a stem cell? Blasts in bone marrow, plus blood, molecular diagnostics. Case 1. Plus. Diagnosis equals acute myeloid leukemia. Bone marrow failure. Blasts in bone marrow, plus blood. Molecular diagnostics. Case 1. The patient receives some chemotherapy presents to A and D pyrexia. Shivery, vomiting, diarrhea. Neutropenic sepsis. Neutropenic sepsis. Treat as neutropenic without waiting for FBC result. Blood cultures. Broad-spectrum antibiotics within 30 minutes of presentation. For fluid resuscitation. Get help. Fungal pneumonia, probably aspergillus. Management of acute leukemia. Chemotherapy. But. Filtered air. No plants or flowers. No unnecessary visitors. Washed food, no salad or grapes or black pepper. Antifungal prophylaxis. Mouth care, indications for bone marrow. Diagnostic. Abnormal FBC. Investigation of paraproteinemia. Bone lesions in pelvis accessible by this route. Pyrexia of unknown origin. TB in HIV+. Foreign travel, splenomegaly. Isolated splenomegaly with diagnosis unclear from PB. Staging. Hodgkin lymphoma, non-Hodgkin lymphoma. Treatment response. Leukemia, myeloma, lymphoma, etc. Case 2. 56-year-old man, back pain, vomiting and constipation. Now 145 calcium 3.25 K 5.7 total protein 126 urea 46 albumin 34 crete 565 HB 8.7. Investigations. Protein electrophoresis, of what? Bone marrow examination, for what? Skeletal survey, is what? Investigations, serum, urine electrophoresis bone marrow examination. Skeletal survey. What is the diagnosis? Multiple myeloma first management issues. Correct calcium. Give fluids. Renal failure in myeloma. Light chain deposition in kidney. Hypercalcemia. Hyperuricemia. Dehydration. Nonsteroidal anti-inflammatories. Plasma cell infiltration of kidney, urine-free light chains, an old story. Previous polyclonal anti-serum against light chains could not distinguish light chains bound into whole immunoglobulin molecules from free light chains. Case 3. 35-year-old woman with 2 years of lethargy and intermittent loop pain. Now complaining of dizziness. Visible white cells. Case 3 on examination, massive splenomegaly fundal hemorrhages. Diagnosis. Chronic myeloid leukemia with hyperviscosity resulting from WCC. Immediate management. Get the white cell count down. Myeloproliferative disorders. Clonal, pre-leukemic. Uncontrolled proliferation of one or more bone marrow lineages. Red cells, primary polycythemia. Platelets, essential thrombocythemia. White cells, myeloid, chronic myeloid leukemia. Fibroblasts, myelofibrosis. Myeloproliferative disorders. Primary polycythemia and essential thrombocythemia. Increased vascular events. Treatment is aimed at reducing these. HB greater than 19. PLTS greater than 700. Ask. Causes of hyperviscosity. Paraprotein, IM greater than IgA greater than Ig. High WCC, CML/AML greater than CLL. Higher red cell mass, polycythemia. Raised platelet count. Greater than 1000, myeloproliferative rather than reactive. Causes of splenomegaly. Hematological. Chronic myeloid leukemia, myelofibrosis. Chronic lymphatic leukemia. Acute lymphoblastic leukemia. Lymphoma, various. Infective. EBV. Chronic malaria. Visceral leishmaniasis. Liver other. HCV/HBV with portal hypertension. Any caused cirrhosis with portal hypertension. Case 4. Indications for lymph node biopsy. Generalized lymphadenopathy, FBC unhelpful. Also palpable cervical lane with mediastinal lane on CXR. Isolated lymphadenopathy, no obvious pathology in the anatomical region drained. ENT, nasendoscopy NAD, FNA unhelpful. Regional lymphadenopathy with obvious primary pathology inaccessible to biopsy. Findings on lymph node biopsy. Reactive. Necrotic. Granulomatous, TB, sarcoid. HIV. Metastatic carcinoma. Metastatic melanoma. Lymphoma. Non-Hodgkin's lymphoma, T-cell. Hodgkin lymphoma. Non-Hodgkin's lymphoma, B-cell, Case 4. Nodular sclerosing Hodgkin lymphoma. Case 4 treatment, chemotherapy, radiotherapy, risks of treatment. Breast cancer. Thyroid cancer. Secondary leukemia, myelodysplasia. Infertility. Other endocrine failure, early menopause. Bones. Cardiac damage, chemo plus radiotherapy. Risks of treatment. Intra-abdominal lymphoma. PET-CT in staging lymphoma. PET-CT in staging lymphoma. Indolent non-Hodgkin lymphoma, localized to one site. Aggressive non-Hodgkin lymphoma,